CareGiver reality show with your hosts, David Levy and Paul Vadiato, who bring you more than a combined 25 years of practical experience, helping thousands of family caregivers, helping them find solutions to the challenges and frustrations presented by this important responsibility. So if you are in the position of caring for a spouse or a parent, a loved one who is no longer able to care for themselves, or if you know someone who is, this hour will be worth the listening. Now, let's tune in to today's edition of CareGiver Reality with your hosts, David Levy and Paul Vadiato.
Good evening, South Florida, America, and the world. It's Tuesday at 5 o'clock, drive time, so you're listening to the CareGiver Reality Hour, and you're listening to us on caregiverreality.com, wwnn.com, amp2.tv, iHeartRadio, YouTube, and just about everywhere else. So you have no excuse not to listen or watch. And we've got some great stuff for you tonight. We have a wonderful guest. She'll be on in a few minutes. She's sitting here in the studio with us. We were up today at the Breakers Hotel, one of Henry Flagler's first when he brought the railroad into Florida, and a conference called Moments of Change that had a tremendous amount of the big players in the addiction recovery industry. It was very, worthwhile. We were able to do 3 live interviews thanks to our producer, Freddie, who isn't even in the studio today. He's managing this whole thing remotely while also running it in Boston and Philadelphia and Atlanta. So kudos to Freddie. He's really advancing the show. As I always ask at this moment, Paul, how was your week?
Well, good evening, David, and good evening to you, our listeners. Thank you for joining us today. David, this has really been a difficult week. I mean, it had its up spots. Debbie and I were able to go out to lunch with friends. First time in a long time. But it also was a week of reflection. And I think Debbie's really struggling with some of the difficulties that she's really going through and the reality of how far it has progressed is really starting to sink in. So I'm kind of stressed from that, to be honest with you.
I know that because you and I spent a lot of time together, and I know how stressed you've been.
How's Suzette doing?
Suzette was a difficult week. You know, she had her left knee operated on in the middle, earlier this year. And so she thought she was going to get away with everything, and now the right knee. And because of her condition, as you well know, she doesn't tolerate surgery, narcotics, or anything else. And the thought of going back through this again, especially after the terrible time that she had with the primary care physician that she had at the time that took her off of all of her dysautonomia medication and made her go cold turkey. And it was a horrible experience. And so she's just like Debbie. She's fearful of having to go back through this while it's still fresh. We only did it in March. So here it is. Tomorrow will be October 1. And, here it is again. And so, we're taking it a day at a time. And
it's like you say, David, caregiving is the gift that keeps on giving.
Oh, boy, does it ever.
Yeah.
And just when you think you've kind of got it settled into a spot,
don't get too comfortable.
Don't get too comfortable because it's going to roll right over on you. Yeah. And so anyway, that's what's going on. And she's not happy about it. I'm not happy about it. And as a result of the limitations in walking and getting around, it kind of isolates her just as Debbie's condition does.
Yeah, it sure does. If I could take a moment, David, I want to thank so many of our faithful listeners who have been following us up on Facebook and have been joining in the conversation and the discussion.
And Twitter and retweeting.
Well, I'll tell you what, I'm struggling through the technology.
Too. Yeah.
I'm looking for the Twitter for Dummies book because
there has to be one.
There has to be one. And I'm going to buy one of those or the Cliff Note versions of it.
Oh, now you've dated yourself.
I know, but it's been a great experience. And one of the things that we always talk about, and I'm really finding out personally, I'm not alone.
60 million of you
Yeah.
that look, although they don't have as nice a shirt and tie on as you do.
Oh, I don't know about that, but it's the problems that we're facing. We talk about every week. I know our listeners; they're going through the same things, and you have that feeling at times. Even us who do this professionally, sometimes you really feel that you're just shouting out all alone, and if you don't have that support system behind you that you can reach out for help, it really gets tough.
Right. And this weekend, because caregiving doesn't care if it's Saturday or Sunday, phone rang. A couple of folks that I had helped out a year or two ago. Well, they think everything was fine, and now it just kind of went upside down again. And they were having a lot of trouble advancing forward with Medicaid to get Dad into a nursing home. And the Medicaid program is still very much intact, and it's funded for what we call ICP, Institutional Care Program. But now that we have added a layer of what I will call managed Medicaid in the state of Florida, now there's an extra mouth and an extra set of eyes and ears whose responsibility it is to save Medicaid money. But also at the same time, that saved money necessarily goes in their pocket. I don't mean individually, but as far as a corporate undertaking. And so I've been having a lot of difficulty getting preliminary diagnoses as to neediness, not just the medical, not just the financial, but cracking through this new system that inherently means well, but hasn't found its feet yet, and as a result of that, the easiest thing to do is say no, and then let somebody come back at you and prove why it ought to be yes. And so both the calls I had over the weekend were almost identical, but for condition and location.
Right.
And so I think this is an issue that our audience, well, even though you may not be anywhere near Medicaid or getting ready to retire, but it's all part of what we talk about in planning for caregiving. Not only do you have to plan what your strategy is going to be and what your money may be and what your resources may be, but you've got to be ready to encounter a system that to date is not very caregiver friendly. And the clinical system has dumped on the informal caregiver every responsibility that it doesn't want to take on. And therefore, every day the caregiver has to figure out, in a system that's constantly morphing and changing itself, rules, regulations, the way somebody does something, whether they don't do something, what's today? I got the rule yesterday, and today it just changed on me. And this is all part of what we talk about when we talk about the system. And there were some very interesting articles last week that talked about the medical profession and their ignorance towards recognizing caregivers and their lack of professional training in advising caregivers, because they're patient-focused. They're there to take care of a disease or a condition or an affliction. And caregiving doesn't come up on their radar as a practical problem-solving issue. And Paul, as you know, I have a number of physicians who have me helping take care of mom or spouse because they don't understand the system any better, and they hate the idea that as doctors, the system just doesn't open up and there's a pathway to a conclusion that they're no different when they're a caregiver,
Well, just
no
to-
matter what credentials before or after your name.
Well, we just heard that from Dr. Hinton a couple of weeks ago, where
Great
he
guest.
said, great guest, but he said all through med school, all through my specialties, never had one class in family caregiving. And I know, in taking care of his patients, he struggles with what happens when they go home, because while they're in the office, he can treat, but once they leave his office, he's depending upon those boots on the ground in the house that are supposed to carry out what needs to be done.
Right. Speaking of boots on the ground, the military,
Yes.
and the VA has admitted this over and over again in the last month. They are so totally unprepared for the caregiver of the military, wounded warrior, whatever it may be, PTSD or a lost leg or whatever the circumstance may be. And people forget, even though we try and remember, that it's not just if it happens to be a husband, their wife, or if it was a female in the military and it's a husband. But because of the age, many of these folks have children who are 5, 8, 9, 10, and completely forget about the fact that these children are as deeply affected with caregiving as the primary spouse or their parent may be. And that I know earlier in my career, when I used to deal more often with children as caregivers, there's a lot of resentment that can build up, because mom can't be a soccer mom because she's taking care of Johnny, or dad takes up all the time, or the son says, it would really be nice if I could have a dad that would throw the football with me, but unfortunately he can't. And so kids don't always understand the enormity of the disease or the predicament, but they sure understand when it got dumped on their watch.
Yeah, and you wonder, why isn't there more help? We certainly understand and we appreciate the men and women who have gone and have fought for our country, and they came back in need of help, and hopefully that help is going to arrive sooner rather than later. But we can't leave these families behind. We can't disappoint, and we have an obligation to give them the support that they need. And hopefully, through our efforts and efforts of other organizations, family caregiving is going to become a more important part of that solution.
Well, it's an essential part of getting anybody back and integrated into society, no matter what their issue may be. And the military, rightly so, has always been very, very clinically focused. All right? You went to Walter Reed and they made you better. All right? And you were the patient, and if your wife or your husband came to see you, all well and good, but that was the focus. And unfortunately, the medical profession in the military is no different than the medical profession on the private side. If you haven't been trained in it, if you don't understand that you need to recognize and not marginalize the caregiver, then you have taken away one of the most essential parts of recovery and therapeutic advancing, because they're the 724 eyes and ears. They're the canary in your loved one's coal mine. They see it first. If they don't know what to do, or they think they're dealing with a hostile system, they're just going to turn around and keep it to themselves. They're going to burn out, and their loved one isn't going to get the kind of, at least, medical care or maybe psychological care that they need, because nobody has asked the caregiver, what's going on at home? All right? It can't all come with a thermometer in the patient's mouth.
Exactly right. Situation really needs to change, and we have an election coming up, and this is an opportunity for our listeners to make your voices known. And on a list of our priorities that we have across this country, this needs to be near the top of the list, is taking care of those men and women and their families.
Right. As well as yourselves.
Yes.
Because anybody that's sitting and saying it's not going to happen to me is very, very wrong. There's no U-turn on the aging highway, one of my trite cliches. So we're all going to get older. We're all going to, and even as a gerontologist who believes in healthy aging, we're carrying with us many of the sins and indulgences of the earlier part of our lives, whether it's obesity, diabetes, other inflammatory things that affect who we're going to be in our 60s, our 70s, our 80s. Maybe you've prepared for it financially, but let me tell you, if you have to put somebody in assisted living for dementia, right now here in Florida, and it's a lot more expensive in other places around the country, you're looking at $100,000 a year. And you could be looking at 5 to 10 years. So as long as you have a stray million to keep a loved one in a dementia facility, all well and good. But there aren't, and also provide for yourself. So many caregivers, well-intended, have spent their last dollar helping their loved one, and all of a sudden they're on welfare.
Oh, David, for 29 years and working in that world, I've seen that happen again and again. It's always done with the best of intention, and unfortunately, in that cost of care, what is not included is providing for the surviving spouse, who at that point is burned out and probably in need of care
Right, and his
themselves.
wallet is burned out, or her
Sure.
wallet. So, I mean, it's a big issue.
David, before we head into our first break today, you were talking earlier about generic drugs and some of the news that's coming out about that. Why don't you share a little bit of what you said?
A couple weeks back, we were talking about the fact that all generic drugs seem to look alike. They're all white round pills. And we used to be able to figure out our meds because it was the triangular yellow one, the square blue one, or whatever the heck it was. We kind of could figure it out by color code. Now they're all coming in, and they look very much alike, so that there's always a risk that somebody's taken the wrong pill.
Yes.
But one of the scary things was a study, not a study, but a report out of Boston yesterday that is highlighting the fact that generic drugs are going up in cost, and the only reason they're going up is because they're unregulated. That doesn't mean that the FDA didn't approve them to come in and follow the patented drug in being made.
Right.
But there are no cost controls. It's a runaway situation. So as long as big pharmaceutical retailers and supermarkets, et cetera, are willing to discount the generic drugs to keep it affordable, but they're going up in price. The middleman that sells to them can put whatever number he wants on those products, and all of a sudden you're going to see the medications that you got for $5 and $10 costing you $50 or $100, and you'll go, why? This is the same script. You know why? Because that's just the way it is. And we don't have any regulatory control over prices. It's what traffic will bear. And so this is something that everybody needs to be aware of, who has taken comfort in the fact that the drugs they were taking have finally gotten off of patent and are available in generic form, even though you can't figure out which one they are.
Well, you know, like at the carnival, they spin the wheel and you hope you have the right number. I mean, I know with Debbie and the meds that she's taking, every
Sounds
time,
like a singing group, Debbie and the Meds.
but it really is. I mean, every time I go to renew a script, you never know what you're going to pay for it. It really needs to have. This is one area we really need to get some control and a handle on the pricing on this.
Right, and you know, we've been talking about the fact that we don't have a lot of new antibiotics in the pipeline,
right?
Because there just hasn't been a lot of incentive for it, even though there's a need. But the example that this report did was they looked at an antibiotic called doxycycline, which has been around for quite a while. It's off patent. You used to be able to buy 500 pills as the drugstore, all right, or even if
Wholesale.
you needed it yourself, wholesale, $29.02. Now, the same thing costs $900. So we went from a pill that was a minimal fraction of a penny to one that's now $1.40. Figure out what that increase and why. And it's because it lives in an unregulated industry, and we're going to see more and more of that. Let's see. It's 5:20. We're going to take our break. Kenny, take us away, and we'll be right back. Don't go away. You're listening to the Caregiver Reality Hour.
CFC support helps fund research. You can too. Each year, thousands of men and women serving their country in the U.S. military, as well as other employees of the federal government and the U.S. Postal Service, provide support for medical research to find treatments and cures for diseases. This is done through the Combined Federal Campaign, an annual workplace giving campaign that allows eligible individuals to support charities, such as those that conduct medical research, through a payroll deduction. Money donated this way to the medical research charities and its member organizations helps fund research to fight diseases from Alzheimer's to cancer, multiple sclerosis, blindness, breathing disorders, and much more. The diseases included afflict people of all ages, from the very young to the very old. You don't need to be a member of the military or a federal government employee employee to support research to help you or those you love that are suffering from an illness or disease. Donations to our not-for-profit tax-exempt organizations are tax-deductible and provide a vital source of funding in the fight to defeat some of life's most dreaded diseases. Please visit the website of the Medical Research Charities, which can be found at medicalresearchcharities.org. That's all one word, medicalresearchcharities.org. On that website, you can learn more about our member charities and make a donation in support of the research they're conducting for a specific disease or family of diseases. You can make a donation to Medical Research Charities itself and support the work of all our member charities. Please visit our website today, medicalresearchcharities.org. Become a part of Joining Forces to Find a Cure. Are you a family caregiver? Are you taking care of a spouse or loved one who can no longer take care of himself or herself? Are you dealing with Alzheimer's disease and don't know what to do? Do you feel burned out, frustrated, and just don't know where to turn? You've tried doctors, lawyers, and mental health professionals and have come to realize that they don't have practical answers to these questions. What you need are experts, non-clinical family caregivers with 25 years of active experience helping thousands of family caregivers like yourself. People who can help you provide a better quality of life for yourself and your loved one. Who you need are David Levy or Paul Vadiato. Reach David at david@caregiverreality.com or reach Paul at caregiverreality.com and let them help you pick the right path towards improving the quality of life for you, the caregiver, and your loved one.
This is Paul Vadiato, co-host of Caregiver Reality Hour. As a spousal caregiver, I know that sometimes things get rough and sometimes we lose perspective. David Levy and I have over 50 years experience and expertise on advising caregivers. If you find that you need help, you're a little confused, reach out to us at Paul or David at caregiverreality.com. We're there to help.
This is Caregiver Reality with gerontologist David Levy and caregiver expert Paul Vadiato, who ask you to call in and speak with him on the air toll-free at 888-565-1470. That's 888-565-1470 to share a story or important information. Now, back to today's Caregiver Reality Show.
And we're back. And once again, we know you're listening to us on iHeartRadio. You're seeing us on WWNN.com, CaregiverReality.com. You're listening to us on 1470 AM if you're here in the South Florida backyard, and AMP number 2.TV. As I said, no excuse not to hear us, not to watch us, not to listen. And we know you are because this audience is just growing and growing. I cannot tell you, because I'm not allowed to for the moment, just how big the audience has gotten, but very soon we'll be able to reveal those stats. But I can only tell you it's in the couple of million. And that's in a very, very short period of time. And one of the reasons is because Paul is so good looking and he has the greatest selection of ties. People are just, they cannot stop watching.
Thank God I'm colorblind.
Right. Anyway, Medical Research Charities, who is one of our sponsors, and by the way, we're getting close to charitable donation time, and they're a wonderful organization, as well as the 29 underlying charities. And because we've been seeing so much, all of a sudden, a lot of kids are coming down with pneumonia, asthma-like symptoms, etc., that aren't really explained. Paul's doing some research on it that we'll be reporting very soon. It's a little scary, but for the moment, today's organization is the Asthma and Allergy Foundation of America. They're the premier patient organization dedicated to improving the quality of life for people with asthma and allergies through their education, advocacy, and research, and they've been doing it since 1953, when I was 20. And AAFA serves more than 60 million Americans with asthma and allergic diseases, and they're headquartered in Washington, D.C. They raise a lot of money. They put it all into research, a lot of it aimed at kids, because kids are very susceptible to asthma, as are older adults, and the more we see in aging America, just like there's chronic obstructive pulmonary disease. We see it because people had asthma as well as other breathing disorders when they were younger, and it has extended itself later on in life into chronic obstructive. So they're a great organization. They do a lot. You can see more about them on www.aafa.org, and you can make a direct donation directly to them, or medicalresearchcharities.org. You make a donation to them. It spreads throughout the organization, and it is really a very, very interesting and simple way to make your dollars count. Not that every not-for-profit out there isn't worthwhile, but these guys really put it together and do it the right way.
They're very passionate about what they do, and please, be generous. It's the right thing to do.
Yep. And speaking of the right thing to do, Paul?
Yes, David?
Yes. Well, isn't the right thing to do right now to introduce our guest?
Absolutely. It really is with very, very tremendous pleasure that I get to introduce an old friend and just a tremendous resource, Dr. Kathleen Bigsby. I guess I've known her now for about 7 years. Kathleen specializes in the treatment of addiction and mental health issues, and she's been since 1990 the CEO of since 1990 and the CEO of the Canyon in Malibu, California since 2005. She works with an extraordinarily gifted team of clinicians and professionals that provide comprehensive and quality treatment. Doctorate in human development, master degrees in clinical social work and family systems. She's also credentialed in alcoholism and substance abuse and a certified grief counselor. Above and beyond all of the credentials, she is extraordinarily passionate about what she does, and she is so caring with all of her people and all of the people who come to help her. Kathleen, welcome to the program today. Thank you for joining us.
Thank you. I'm honored to be here.
Right.
What a
And
thrill.
before the show, Kathleen, I said to her, you have to sing. And she said, I can't sing, but I can hum. So if you hear a little hum going on in the background, all right, it's probably Kathleen. And we're extremely pleased to have you here. And I know from just the little bit we talked about that an earlier time in your life, you were a caregiver, and you wanted to discuss some of the things that happened to you when you were younger. And take it away.
I wanted to just acknowledge the safe haven that you've provided, David and Paul, has been extraordinary. I've been watching your shows, and your handbook is something that so many people will be touched by that. Individuals that are spouse caregivers, children, knowing that there are resources, places to go, people to talk to. When I think of what caregiving was when it happened for me, I was a teenager. I was in high school.
Well, that wasn't that long ago.
And I really love you.
Hum it.
We'll get to the humming and the chair dancing later. I think the thing that when you look at caregiving and you look at diagnoses and understanding what's going on medically is something that is very practical. It's concrete. It's understandable. When the family is struck by multiple illnesses, there is a sense of illness and suffering that can become a part of the family environment. And I think for us, I was in high school, my brother was in law school, my sister was in college. We had my mother had chronic long-term illness, rheumatoid arthritis. She was the individual that had the diagnosis. I think what created a different environment was when my father had an acute illness, cancer, within a 6-month time frame from his diagnosis to his passing. There was a sense of a loss of hope. We felt very alone and uncertain. I was the person that was driving them back and forth to their doctor appointments, and didn't really know what to do other than keep doing. And out of all of that, I think that is, those defining moments in your life
Oh, yes.
where you have those experiences, and I call them my core virtues and my core beliefs. I believe everyone deserves a safe haven, family members and loved ones that can really connect and be together, that you're not alone, that your show, your guidebook, there are resources. You don't have to feel you're in isolation. That's what really promotes a sense of hopelessness. And so for me, when I think of what's necessary is we need to support the family. It's sometimes the individual that has the diagnosis gets care, and the caregiver, the one that is stressed,
In the trenches.
moving, back and forth to appointments, making sure that there's the list of questions for the doctor and making sure you understand all the prescriptions. But the stress of the caregiver is something that your guidebook and information on your show is really helping individuals. And for me, I just feel so inspired by what you're doing. I wanted to thank you. And I'm proud to be at your show because it's something to me that has guided my life, making sure that families are included, that you're never alone, that there's hope. And there's a way to get past that moment that you feel is impossible.
Let me ask you a question. And as you said, within a short period of time, even though your mother had chronic rheumatoid arthritis, and then Dad was diagnosed with cancer, and it moved very quickly. When he passed, did your mother change? I mean, I know obviously the loss of her husband changed, but did she then view her illness as more terminal, or that this is going to happen to me much sooner because look what just happened to Dad?
I don't know if she felt that way. I do know that she felt a tremendous burden and responsibility. She was a stay-home mother, and my father was the primary breadwinner. And so it was completely unexpected to have my father, who is out in the world, making sure that we were provided for financially, just the day-to-day of going to the store and making sure that everything's taken care of. With that being gone, I think she wasn't sure what to do, and she wasn't sure where to go. She, I think, became even more determined that she would be as mobile and healthy as possible, and it became her mission to stay as healthy as she possibly could. So I think she became even more driven to be the parent in the family, to be available to all of us. It was something that I'm blessed to have an extended family where rallying together once we all realized the impact. I think the immediate support was to my mother because she had just actually had a surgery before my father was diagnosed and passed away.
Your plate was very full.
It was really complicated, and so the immediate resources went to my mother as it would be practical. You would go towards the person that is the most acute. And as that stabilized, we then, after that year of your world flipping over, I think we all were able to better connect and anchor. And that, to me, is why I became so passionate about how we always are working with the entire family. Not just the identified patient, not just the immediate, the spouse, but how do we truly engage the children and everyone to make sure that if we're attending to something, one person changing can affect a positive change in the whole family system.
Well, there's a balance, as we both know. And once somebody changes, for the better or for the worse, that balance changes, and everybody has to kind of figure out how to get back in balance. I have a feeling, and I'm almost positive, that your experience as a teenager and being confronted with the extent of caregiving that was kind of dropped in your lap, like it or not, has probably created, because you can hear it in your voice, the passion that you have for what you do as CEO at the Canyon. And so I think your philosophy and what you learned becomes a driving principle within the corporate walls of what you do and your personal reflection on the people that are there. Am I far off the mark?
Spot on. I call it hard-won wisdom. I feel like I had the blessing of gaining it early in my life, and so it's been my mission to make sure that we are serving everyone we possibly can to truly be of service, not just with our immediate world, but how do we go beyond what's directly in front of us? And truly, that is what I think we all are trying to do. that's you're collecting donations for different organizations. If we all do that, we all can make a difference.
Sure.
Yeah.
And you make a difference one person at a time, especially in caregiving, because essentially, at least when I first engage with somebody, it's the caregiver. And then you find out all of the dynamic that goes behind that, sibling rivalry, second marriage, not my mother, and all of the things that we're both well aware of.
People rolling down the hill.
Paul talks about that all the time, but taking the family and looking at that whole dynamic and the balance of everybody in it, I think is so essential. And
Being honoring and respectful and not judgmental or accusatory. When you think of caregivers, the pressure and the responsibility, and for the caregiver, you can feel resentful. You're doing all these other things for other people, and you still
and where's my reward?
Right.
Where's my pony under the tree?
and you still feel, and you're judging yourself, you're not doing enough. That you could do it better. You could do more to make sure that everything is stabilized. There's a tremendous amount of stress and pressure, and so how do we attend to everyone and make sure that there isn't that accusatory or judgmental or shaming way of being?
Right.
Kathleen, I was privileged to be out to the canyon and visit and to sit in on a session where all of the clinicians were discussing the various patients that were there at the time. Couple things. The first thing that came across was the empathy among the clinicians when they were discussing the cases that they were working with. And the second thing, and I've been around a long time and I've seen a lot of care situations, was the complexity of the cases that you were working with. And while the addictions were a very significant issue, what I guess was called dual diagnosis, which I'll let you explain a little bit, they were just so complex and confounding that it's really miraculous as to the results that you're achieving. Can you speak to that?
Yes, I would say creating a culture of hope is critical for everyone, and that is something that we all suit up and make sure that we have that positive approach and strength-based. It's very important to look at what are someone's skills, what do they have, and how do we strengthen those while we're working on the areas that the person is struggling with. For that question, it's a wonderful question. Dual diagnosis, or dually diagnosed, that name became more precise in 2005. The SAMHSA clarified calling it co-occurring care or co-occurring diagnoses and providing treatment. Providing best care when you're working with someone is looking at both their mental health and addiction issues concurrently. When we look at historically how we've treated diagnoses, I think in 1967, the AMA identified addiction as a disease. And still, through the 70s, where there was the judgment and shame, and alcohol is a moral issue. Unfortunately, we as a culture had that kind of perspective or paradigm as to how we were interpreting addiction. When we started making sure that we were helping people get into treatment, our healthcare system is set up in a bifurcated process where there is addiction care and then there was mental health care. And so treatment was sequential. You would go in for your mental health needs and then go in for addiction care. Not having it integrated, there were individuals with high levels of relapse. And when you think about it, it makes sense. If you're using addiction to quell or to slow down some of your anxiety or to help slow your thought process down, or if you're feeling depressed, if you take that away, those other symptoms are just going to exacerbate.
Bubble up, yeah.
Right? We don't know causal effect, addiction or mental health yet. The neuroscience isn't quite in yet. But we do know that you have to treat them concurrently. And I think what the Canyon does so well is all of our company, Foundations Recovery Network and the Canyon Treatment Services specifically, we are a co-occurring integrated treatment program that's evidence-based. And what that means is we follow SAMHSA criteria. We make sure that our protocols are being motivational and empowering. The staff is highly trained in all diverse areas that will truly help individuals get care. And we research what we do. Sometimes I think folks have a perception that an individual comes in, and if they're not motivated for care, and they could say, oh, I don't really have an addiction problem, that we could get off on the wrong path. What we do is we do comprehensive assessment and evaluation, and we gain an understanding of what's been going on in the person's life. We may not necessarily know causally what occurred first, but we can get a sense of the pattern of what occurred. With that, we can do evaluation on admission. We do evaluation at exit, 30 days out, 60 or 6 months out, and a year out, and we can evaluate how are we improving the quality of someone's life with both their mental health and addiction issues. And what we have found through our evidence-based practices and through using highly trained staff that you experienced, 59% of our patients, 1 year out, within that 30-day period, 1 year out, 59% did not experience symptoms of mental health concerns. Of those that did, they experienced symptoms for 4 days. Now, when you think of mental health issues, you're talking about reduction of symptoms and improvement in quality of life. That is extraordinary. In terms of the addiction issues, we looked at, again, 1 year out within that 30-day period, 85% of the individuals were no longer using alcohol. And I believe it was 91% in this data set were no longer using drugs. Now, when we're talking about co-occurring integrated treatment, we were attending to both issues concurrently, and we were managing both at the same time. Going through aftercare planning and follow-up care, you want to make sure that both are being attended to so the person isn't struggling with one or the other once they leave. To me, that's quality care. That's where we're seeing the most improvement, and our patients are feeling it. They complete patient satisfaction surveys. We do a lot of them, I must say. We learned that we thought we knew what was best, and so I'll give you an example. At addition,
Until you ask the people that are going
and
through
they
it.
give us the wisdom. Why didn't we ask first? We thought at admission we would have one person take the luggage, one person do the assessment, another person show them around and tour and orient. And we got feedback, far too many people helping. Just please, let's have one person walk us through the whole process. So what we learned is our patients are our guide. So we do admission surveys, we do weekly surveys, we have community meetings, so in the moment we're talking about how the experience is going. We do exit surveys, we have family program that we have surveys, and what we have found, and the evidence supports it, and the research supports it, that patients that are satisfied stay in treatment and have better outcomes.
It sounds
that
like
simple.
Makes sense.
It sounds like they came to be serious, and they thought they arrived at a hotel, and here's the bellman, and here's this person and that person, and they were really looking for one person and to get the action going.
Yeah. Kathleen, as you know, in my former life, we had worked together with a
Yes.
family, and I saw that, having been to the Canyon, I knew from the clinical side what was going to happen, but I also experienced it through the eyes of the family. And I know it was quite a number of months before they were ready to take that step, and the difference that it made. And as their loved one was going through treatment, it was a roller coaster ride back at home, and yet they had that support from the Canyon in helping them through that period of time, because the stress levels were just incredible when they were leaving. And while they were in recovery, the absence of that stress was causing stress.
It's the unexpected.
Yeah.
When you're familiar with a certain way of being, it's hard to make a shift. That's why it is so important to have family program and to talk about healing the family. Years ago, again, back in the 80s, when we were just getting ourselves organized in terms of care, there was a sense of people coming to family program where they felt they were going to be confronted. And we wondered why we didn't have many families involved in coming to family program. Well, if You thought you were going to go to a group and be blamed for the problem. Why would you go?
Sure.
What we know and what the research supports is healing the family, having a proactive focus on how can you walk away from spending time together as a family and learn how to better take care of yourself. Shifting that focus and knowing how to self-soothe, figure out what's going on for yourself, you can have healthier boundaries in a relationship with the individual that may have the highest need at that moment, but not necessarily the only one with a problem in the family.
Right. Well, that's very. We see the identical thing in non-clinical family caregiving because it really doesn't change. You're dealing with one aspect of a problem that has a focal individual who has an addiction. We're dealing with a family that has somebody who has got a chronic illness or a terminal illness, and that's the focal part of it, but yet the dynamic of the family either has to come together or it disintegrates very quickly, whether it's sibling rivalry, whether it's somebody who just says, I'm so burnt out, I have no support, I can't keep doing this, I'm out of here. And so when you're involved in care, whether it's your version of care, our version of care, there really isn't a lot of difference. What we see in difference is what is it that the patient is going through, and the same amount of guilt, denial, anger, resentment that comes up with our caregiver comes up with yours. The only thing at times is that we don't necessarily, it's in the sense of what you may see where they don't want to be accused of, being an enabler or of having started the addiction. We don't have anybody that comes in and says, well, you're going to yell at me because I caused Alzheimer's, and that's really the only issue that distinguishes what you're doing in addiction and what we're doing in chronic illness. And if you really think about it, chronic illness, if you can't get your arms around addiction, is exactly that. It's a chronic disease, a chronic illness. And you can't blame them for having a disease that, and I guess it's what you were talking about from the 70s and the 80s, that stereotype that came about that said, oh, well, you didn't have to pick up that first glass. You didn't have to take those pills. Well, you don't know what was going on in my head. I just didn't decide, one day that I was just going to become an alcoholic. Something drove me there, all right? Whether it was peer pressure, whether it was the thrill of discovering something that looked like forbidden fruit, and all of a sudden, wow, I like it.
And then the genetics of it.
Or the genetics of it, of course. So, and I can understand the complexities. I see our complexities, but when you've got, kind of that confounding and dual diagnoses kind of situation, that's really, you really got a matrix there that you've got to piece apart and keep apart as they go through the process so that it doesn't re-knit the moment they're out the door.
And acceptance and stabilization of all of it. And oftentimes it is psychoeducation for the family to better understand that, when you think of addiction, think of type 2 diabetes, think of hypertension, there's genetic risk factors. There are environmental stressors, environmental risk factors. And when we look at when you're struggling and you're trying to keep up a lot of stress, there could be alleviation of the stress by having some alcohol. So the immediate experience is relief. Alcohol, it releases dopamine in the brain. And so there is an ease, there is a comfort. And so early stages, that seems to be helpful.
And it's socially acceptable.
It's a legal drug. It is the highest use drug still in this country, alcohol. With that use, it's unfortunately reinforcing because it's a chemical that's releasing dopamine. And it's in our midbrain. The mesolimbic dopamine system is where the disease is. And what happens is with food, dopamine is released. And so dopamine is a good thing in our body, our neurochemistry. It's a positive thing. But what happens with chemicals it's reinforcing. And so an individual with environmental risk, with genetic risk, and they're using alcohol to quell or soothe the stress, that's something that it becomes a horrific cycle, and then it becomes out of control. They become dependent on it, and it becomes a challenge to learn how to not do that just by saying, well, I need to put that down. Well, just saying no, we know, doesn't work.
No way.
There was a good effort to do that.
It worked for Mrs. Reagan.
A beautiful message.
Right.
But our brain chemistry wasn't buying into it. We
Right.
have to learn the skills. And so going to treatment and changing the brain chemistry back, having dialectical behavioral therapy or cognitive therapy, and learn how to reprogram, there isn't that craving or that drive to have the dopamine release with the chemical. That's what we can do to affect change. So it's not a judgment, it's not a moral issue. It's having awareness that it's a disease, and then you can change it. You have
Right.
control once you learn what that process is and choose not to drink
Absolutely.
or do drugs.
And thank you, because that was a very easy to understand, other than the midbrain limbic, which may have left a few people out there. But you really kind of took a very complex subject and made it understandable. And I think that's, I had a chance to speak to you before the show, and that seems to be something that you do, whether it's by your training or who you are. You have an ability to take a complicated subject and kind of break it down and make it make sense. And I think for our audience tonight listening to you, they got a lot out of it. I know I did. So if I did, they did. Right, audience?
Kathleen, well, it goes by so quickly, and we have a few minutes left. We talk about how do people buy nursing homes. Intrinsically, they don't know. And people, when they're looking for recovery, how does one decide what should they be looking for if they're looking for a recovery center?
That's an excellent question. I must tell you that it can be very challenging to find good care.
No kidding.
Right?
Yeah.
And so we want to be thoughtful consumers. And I think the thing that I am incredibly proud of with Foundations Recovery Network, not only our conferences where we want to help move forward all evidence-based quality care and treatment and educate with our research, with our treatment, we want to make sure that individuals are making good decisions of what's a good match in terms of geographically where in the country would it be best to be close to family or move out of the
Away.
area, to make sure that it's you have the resources to go into residential care and have good aftercare planning, a significant period of time to learn your new skills, practice your new skills in structure, and have ongoing support and hopefully some monitoring for a period of time to really reinforce the new skills that you're learning. With all of that, you can look on the websites and see really attractive looking places. And the Canyon is one of those beautiful places. It's a 120-acre property. It is in Malibu. It is absolutely exquisite. But that doesn't eclipse the brilliant clinical program, the evidence-based integrated treatment program. Look on those websites, look for the research, see what they do. Foundations Recovery Network has a wonderful website where all of our research, our white papers, all of what we have done to move forward the thinking and how to make sure we're providing best clinical practice and best clinical care. Look for individuals that are doing that. It's a good indication that we're constantly trying to improve the quality of what we do. We have our conferences twice a year because we want to learn what's going on in neuroscience. In the next decade, we are going to learn so much more about what happens in the brain and how we can improve the quality of what we do. That is exciting. We can better help individuals. So please do your homework in advance. If you are in crisis when all of a sudden you realize that something is upon you, we welcome you calling our admission center. We will take any caller, answer any questions. If there are different parts of the country where you may not be certain if it's a right fit for you or if they take your insurance, we will help you make those decisions. It's just free of charge. We will support you through that process and being placed, whether it be with us or any other place that that we know will provide quality care for you.
What's the website besides thecanyonmalibu.com, which is specifically the Canyon?
Thank you.
Where is the corporate site that has more of that information on it?
FoundationsRecoverynetwork.com is where you will find all the research and all the information, and it will have telephone numbers to our admission center. But I'd also like to tell you the admission number is 888-980-4321. That is 888-980-4321.
Kathleen, in the few minutes that remain, what would you like our listeners to take away with them from your visit today that would really be of help to them?
Don't be alone. You're not. There are resources available. I think all of the family you were talking about that we worked with, the families that we treat, I think it's the father that is using alcohol, has depressive symptoms, has a lot of responsibilities, that's feeling he can't get away. The mother that had pain issues and was prescribed oxycodone and is not sure how to manage her anxiety and has children and a caregiver. It's us. It's all of us. It's not, I think sometimes we put away and we look at it must be someone that is not like us. We all need help. We all need support. We all can have an extraordinary life if we reach out and ask for help, and we'll be there to support you.
I think that is the key word. Anyway, South Florida, America, and the world, you've heard a wonderful, interesting PhD lady who kept it in simple speak, didn't hum, didn't dance in her seat. We'll have to have her back to do that. Paul?
Thank you all for joining us this week. And as always, caregivers, please take care of yourself. Have a great week.
Thanks for joining us for this week's Caregiver Reality Show. Each week, David Levy, a gerontologist, and Paul Vadiato, a caregiver expert with a combined over 25 years of experience providing practical and realistic help to caregivers struggling to keep up with the needs of a loved one who are unable to care for himself or herself. To reach David Levy, email him at david@caregiverreality.com. Or to reach Paul Vadiato, email paul@caregiverreality.com. And find out more online. Just go to caregiverreality.com. See you next week for another exciting show of Caregiver Reality. The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and callers.